Good morning, everyone. My name is Akitatsu Hayashi from Lymphedema Center, Kameda General Hospital, Japan. I'll be glad to have the opportunity to present here. To begin with, I'd like to introduce Kameda Medical Center briefly. Our center was founded in the 17th century during the era of samurai. Privately owned and operated in Kamogawa City, Chiba Prefecture, Japan. Our center includes Kameda General Hospital with more than 1,000 beds, and outpatient clinic features a high-tech diagnostic imaging center and averages more than 3,000 patients daily. It takes just 1 hour from Tokyo International Airport by car. Our center also has Kameda Kyobashi Clinic, which is a satellite clinic in Tokyo. So it is located by Tokyo Station, enabling patients to visit from all over Japan using the rapid train and airplane. Newsweek has ranked our center the top 50 world's best hospital in the world in this year. And also, our center earned the number 3 ranking in Japan. Our center directly fronts the Pacific Ocean and epitomizes today's state-of-the-art medical facility. So this is very nice view from our wards. So I can always refresh after the surgery and outpatient clinic. There are 30 operation theaters in our main hospital, and over 200 surgeries for lymphedema are performed annually. Our center has started from 2019 and being the first Asian designated surgical centers of excellence by the Lymphatic Education Research Network, LENRN, in USA. My specialized field is microsurgery for reconstruction and super microsurgery for lymphedema. I had invited surgery in 10 countries ever for super microsurgery of lymphedema and other reconstructive surgeries. These are the pictures of live surgery and invited surgery in abroad. This is my latest invited surgery in China in 2019. Before COVID-19. This time, I have to thank Dr. Yang for giving me this precious opportunity. Our friendship started from 2015 when I worked in Tokyo University Hospital. So we have collaborated together in many places ever. He has published many important papers about lymphedema surgery. I never doubt that they will be historical papers in the future. So he is one of my best friends in the world and also always spiritual mentor for me. There are 3 things I like to cover today. Firstly, I will talk about what is the cancer-related lymphedema. Secondly, how to manage the treatment for lymphedema. And finally, I will explain new imaging techniques and new surgical concept for lymphedema surgery in our center, which we discovered world first. Okay, I'd like to start it by looking at what is the cancer-related lymphedema. Lymphedema of the extremities is a chronic debilitating disease. Secondary lymphedema related to breast cancer, prostate cancer, and ovarian cancer are progressive in nature, and its treatment is always challenging. The more severe it becomes, the harder it becomes to treat. In the case of secondary lymphedema, the lymphatic vessels in extremities become sclerotic over time after lymph flow obstruction. They lose their function to drain lymph fluid along with thickening of tunica media and separation of each lymphatic endothelial cell. Another important point is lymphatic duct collect not only lymphatic fluid but also excess fat and protein. So in the end stage of lymphedema, fat deposition and fibrosis occur because of them. This is simple figure which shows fluid circulation system of human. In cancer-related secondary lymphedema, the number of lymphatic vessels which cannot converge into the vein after lymph flow obstruction are getting a little bit more. Nowadays, around 25% of patients who had breast cancer and gynecologic cancer will have lymphedema. It has been reported that lymphedema affects as many as 200 million people worldwide. Lymphedema diagnostic market has been, of course, getting increased up until now and from now on. So when is the most frequent timing of occurring lymphedema? 70% of patients had a lymphedema within 3 years. So this is a voice from around 7,800 cancer patients. What is the most frustrating thing for them? One is depilation with anti-cancer agent. Second is numbness with anti-cancer agent. Third one is lymphedema. Okay, let's move to next topic. How to manage the treatment for lymphedema. The mainstay of secondary lymphedema is conservative therapy, like skincare, lymph drainage, compression therapy, bandage, and exercise. On the other hand, surgical treatment for lymphedema, including lymphatic venular anastomosis, LVA, and lymph node transfer, started appearing on the scene. And I think they are effective for the case refractory to conservative therapy and have rapid progression. LVA is the least invasive lymphatic surgery and considered first for compression refractory lymphedema. The aim of LVA is to create as many lymphatic drainage pathways as possible while preserving the remaining lymph nodes. This technique has developed from supermicrosurgery, an anastomosis technique for vessel of under 0.5 mm in diameter. So we always use a thread and needle, which is a size, which is 1/10 or 1/15 of our hair. This is short highlighted movie of LVA. So below one is a vein, and above one is a lymphatic vessel. So this is a vein. Now I'm cutting the vein, and this is a lymphatic vessel. So we selected the fashion of anastomosis for each degeneration status. So now I'm washing the inside of vein, and I'm cutting the hole. I'm making the hole besides of the lymphatic vessel. We sometimes use stent like this. Stent prevent us from suturing the wrong side. Now I'm starting the suturing. So anastomosis is proceeded carefully, gently, and patiently, stitch by stitch. So now I'm suturing the back side. Now it's front side. So stent will move out before the final suturing, like this. So this is a side-to-end anastomosis, and this is end-to-end anastomosis. This is a postoperative course, 3 days postoperative course of breast cancer-related lymphedema, moderate stage. And this is also moderate stage. This is a severe stage of breast cancer lymphedema, like this. This is post-operative 6 months. This is a secondary lower limb lymphedema, post-operative 4 days. This is moderate case. This is also moderate case. This is post-operative 3 months, front side, back side. This is severe stage of secondary lower limb lymphedema. This is post-operative 3 months. This is post-operative 2 years. This patient is a prostate cancer-related lymphedema. This is post-operative 3 months, 6 months, from backside. This is a post-operative satisfaction for LVA from the voice of around 800 cases. Number 1 is improvement of pain and numbness. Number 2 is improvement of heaviness. Number 3 is volume reduction. Quality of life score, including physical function, mental function, household activities, mobility activities, and life and social activities, these are also improved after having LVA. The incidence rate of cellulitis episode also improved. But if there is no functional lymphatic vessel, LVA will not work. And also, LVA cannot change the severe fat deposition. For those cases, lymph node transfer and liposuction could be additional or alternative surgical options. Lymph node transfer is also a physiological lymph reconstruction. At first, lymph node is harvested from supraclavicular, submandibular, lateral chest, and groin region. Next, harvested lymph node is transferred to a lymphadenmatous region with vascular anastomosis. Lymphangiogenosis takes place between a transferred lymph node and the surrounding tissue, and congested lymph is drained into the lymph node via the lymphangiogenosis and then into venous circulation through native lymphovenous shunt within the lymph node and via the anastomosed drainage vein of the lymph node. So liposuction is another additional option for patients who have severe fat deposition. So liposuction is the only surgical procedure to change the accumulated fat within LVA lymph node transfer cannot. So this is a result of liposuction. So, considering current lymphatic condition and subcutaneous tissues, the single procedure or combination of them will be chosen. Although debulking procedures and liposuction are relatively uncontroversial, the physiologic procedures including LVA, vascularized lymph node transfer, and vascularized lymph vessel transfer remain debated. So third topic is new imaging techniques and new concept for lymphedema surgery in our center, which we discovered ever. These are the strategy of lymphedema treatment in our center. One is establishment of early diagnosis system. Second is evidence-based conservative treatment. Third one is design of more effective surgical treatment. Especially, I have put my effort into third one using imaging modalities. Among three procedures, LVA is still the most questioned. Favorable and poor results are nearly equally reported in reviewing the literature. What caused such disparity? In my experience of more than 2,000 cases of LVA, the procedure is highly effective when performed with proper patient selection, lymphatic selection, and patency evaluation. So let's start from patient selection. So LVA only works in patients with fluid predominant lymphedema. When performed in patients with solid predominant disease, both the patient and the surgeon will be disappointed because no meaningful bulk reduction will be achieved. So I personally think physical examination, MRI, ultrasound, lymphoscintigraphy, ICG lymphography, and bioimpedance spectroscopy are very important examination for patient selection. Next is lymphatic selection. Having confirmed fluid predominant disease, next we have to consider the quality of the lymphatics. The efficacy of LVA is largely determined by the quality of lymphatics. The lymphatic vessels become sclerotic over time after lymph flow obstruction, as I told before. So in the process of thickening of tunica media, the lumens of the lymphatic vessels turn to be narrow gradually and lose their function to push the lymphatic fluid to the center of the body against the gravity. So LVA built using functionless sclerotic lymphatic vessels will not move lymph so much. In other words, anastomosis in the severely sclerotic lymphatic vessels leads to minimum therapeutic effect in LVA. The quality of lymphatics can be assessed both preoperatively and intraoperatively. First, preoperative assessment can be performed using ICG lymphography and ultrasound. The quality of lymphatics can be assessed both preoperatively using ICG lymphography and intraoperatively with direct microscope visual evaluation of the lymphatic vessels. ICG lymphography is a minimally invasive imaging modality that can determine the location of the lymphatic vessels as a linear pattern. As lymphedema gets worse, it cannot show precise lymphatic flow because lymphatic flow is masked beneath dermal backflow. ICG lymphography showing severe injury patterns is a negative prognostic factor. So nowadays, most of surgeons usually uses immediate ICG lymphography before LVA and try to find the lymphatic vessel, which is responsible for lymph fluid leak in proximal. As you know, it is easy to find in early stage. But it is difficult to find in the moderate to severe cases, which showed immediate dermal backflow after injection of ICG, even if using multi-lymphosome ICG injection. Also, it is important to note that ICG technology has limited penetration through tissue and does not visualize lymph vessels location deeper than 1.5 cm. So, the absence of linear pattern only indicates that additional effort needs to be spent in searching for qualifiable lymph vessels. So in this situation, the lymph vessel can usually still be found by using ultra-high frequency or high-frequency ultrasound. A noteworthy fact is ultrasound can detect not only lymphatic vessel, but also size-matching vein within a short distance, because incisions should ideally be placed where lymph vessels and veins are in proximity. This technology to plan LVA incision has been shown to increase the success of creating LVA in each incision and decrease the size of incision. So you can see the mosaic pattern in the vein. You cannot see the mosaic pattern in LVA because the flow speed inside of lymphatic vessel is very slow. From our studies, compared with histological study, high echoic region around the low echoic region show degenerative status of smooth muscle cells and hyperplasia of collagenous fibers in the lymphatic vessels. So we can select the best lymphatic vessels in each point preoperatively using this ultrasound. So this is a practical example. This case is moderate secondary upper limb lymphedema. ICG lymphography showed immediate dermal backflow after injection of ICG in form. Although we couldn't check any lymphatic route here using ICG lymphography, we could see not only lymphatic vessel under superficial fascia but also size-matching vein, which is a branch from main trunk. So we could detect them very precisely around 3 mm below the skin. This is an intraoperative picture after dissection of lymphatic and vein. You can see they were located as ultrasound indicated. Second, intraoperative assessment can be performed with direct microscopic visual evaluation of the lymph vessels or using ICG fluorescence imaging mainly. During direct microscopic visual evaluation, we should selectively recruit normal and ectatic lymph vessels and avoid contracted and sclerotic lymph vessels as possible as we can to achieve high-functioning LVAs. This way is very easy and simple but can be subjective, requiring a lot of surgical experiences. Microscope-integrated ICG fluorescence imaging is often used for this purpose intraoperatively. Although ICG-enhanced lymphatic vessel has been considered functional for its capability to transport contrast-containing lymph, and non-ICG-enhanced lymphatic vessel not functional. But it was reported that there are some lymphatic flow positive and thus functional lymphatic vessels that are not enhanced by ICG fluorescence imaging. Dr. Yang already reported this also. Although we reported non-invasive intraoperative imaging of the lymphatic vessel using ultra-high frequency ultrasonography. And images are very informative, but this technique is time-consuming and highly operator dependent because probably of the ultrasound device has to be placed directly on the lymphatic vessel, which was soaked in saline always. The third key to success of LVA is patency evaluation. As of now, in all previous reports, patency of the anastomosis site was evaluated via intraoperative ICG observation, where in most cases, the lymphatic vessel distal to the anastomosis site was milked to push the lymphatic fluid through the anastomosis site. While this procedure may be optimal for assessment of leakage in the anastomosis site, the patency will be determined as positive even in anastomosis with a minimum patent lumen. Furthermore, there are some functioning lymphatic vessels in which ICG is not taken up, making evaluation difficult. From these reasons, a new modality for intraoperative finding the functional lymphatic vessels and patency evaluation, which is comfortable for surgeon and contribute to better result, was warranted. If the thickness of the lymphatic vessel wall and the diameter of the lumen can be measured before transecting a lymphatic vessel intraoperatively, high efficacy of LVA can be expected. Furthermore, if the patency of an anastomosis can be confirmed immediately after LVA, even in small vessels, it should also contribute to better results. In this article, we present new capabilities of laser tomography for imaging of the lymphatic vessels, for intraoperative selection of appropriate lymphatic vessels, and for evaluation of immediate post-anastomosis patency, which may outshine conventional techniques. This technology, laser tomography, has significantly refined clinicians' approach to diagnostic, management, and surveillance of ophthalmic diseases ever. It is an imaging modality that uses reflection of near-infrared light to generate images and provides high-resolution cross-sectional and tomographic data. Using this technology, surgeons would potentially have immediate feedback on completion of surgical tasks or new understanding of anatomic configuration of the tissues. I thought microscope-integrated laser tomography could provide specific real-time guidance for surgical manipulations and selection of functional lymphatic vessels for LVA in 2019. To the best of our knowledge, this is the first study to focus on imaging of the lymphatic vessels using intraoperative real-time laser tomography. Surgeries were performed under local or general anesthesia and were assisted by this machine and focus Ultra HD optical coherence tomography system, which was combined with ProVel 8 microscope from Leica, thus allowing intraoperative real-time laser tomographic imaging with immediate feedback. In this study, dynamic scan is controlled via foot switch for swift adjustment of the scan angle to align with the ICG-enhanced lymphatic vessels. Imaging data are displayed on external screen-based display, this one, immediately after completion of scanning. A trained mechanical engineer or nurse assisted intraoperatively with laser tomographic image acquisition and collecting surgeon feedback and data. This system provides an imaging depth of 2.5 mm at an optical axial resolution of under 4 micrometer. Images are required at 32,000 cross-sectional scans per second. The scan length is up to 16 mm. These are lymphatic vessels. This is a real-time image of the lymphatic vessel on the monitor. The black and white scan expresses the strength of the reflection of near-infrared light against subject objects in this system. White color represents the most intense reflection, and black color represents the weakest reflection. The lymphatic vessel wall was demonstrated as a white region, and the lumen of the lymphatic vessel was demonstrated as black region in laser tomography images. What is remarkable about this system is this green square. So we can see where we want to see in the lymphatic vessel by moving the green square freely. In this study, using the obtained cross-sectional images of the lymphatic vessels, the diameter of the lumen was measured and recorded during surgery. After using papaverine for preventing contraction of vessels, which leads to thickening of the wall. Although the thickness of the lymphatic vessel wall was measured at 4 points, and the average was calculated and recorded. Another noteworthy point is this system can calculate diameter to 3 decimal places. So you see, this is the size of inside of lumen. So the size is 0.149, and the wall The size of wall is 0.105. A small portion of the IgG-enhanced lymphatic vessels which were used for LVA were obtained and sent to histologists after operation. Histochemical staining with elastic muscle stain was performed for evaluation of degenerative state changes of smooth muscle cells and hyperplasia of collagenous fibers in the lymphatic vessels. The thickness of the lymphatic vessel wall, including collagenous fiber layers and smooth muscle cells, was measured at 4 equally distributed points by histologists, and their average was calculated and documented. The correlation between the thickness of lymphatic vessel wall obtained via laser tomography and the histologically measured thickness was examined in 132 IgG-enhanced lymphatic vessels. The correlation between the thickness of lymphatic vessel wall measured with laser tomography and histologically measured thickness was good to excellent. What does this technology bring supermicrosurgery? How can this technology make a contribution for supermicrosurgery? From our preliminary study, it was revealed that there are 3 or 4 main benefits from laser tomography for LVA. First, surgeon can avoid harming the fragile lymphatic vessels, even if they exist in superficial layer or in hard fibrotic subcutaneous tissue, because it can indicate the exact location of lymphatic vessel before dissection. This is example. You can see the 3 lymphatic vessels. These 2 lymphatic vessels converge. Again. So this is a vein. Inside the vein, we can see mosaic pattern. Because this can visualize the speed of flow. So the speed of flow, lymphatic speed of flow is very slow, and the vein, it is fast. So even the lymphatic vessel is located under strong fibrotic tissue, of course, this machine can show where is lymphatic vessel very clearly. Second, this study revealed that laser tomography can provide objective information regarding the thickness of lymphatic vessel wall, which correlated with histologically measured thickness. As I mentioned before, some previous studies reported that classification of the lymphatic vessel condition is possible by intraoperative observation of the transected lymphatic vessel under microscope. However, assessment of intraoperative findings under microscope can be subjective, requiring surgical experience. For example, these 3 dissected lymphatic vessels have similar appearances and not colored in IgG fluorescence imaging. So we cannot understand which lymphatic vessel is the most suitable for LVA. So this is a real-time image of these 3 lymphatic vessels using laser tomography. Laser tomography not only showed unprecedented clear image of the lymphatic vessels even with the vessel with diameter smaller than 0.3 mm, but also demonstrated high ability for intraoperative evaluation of lymphatic degeneration status, putting us a step closer in choosing the ideal lymphatic vessel for LVA. This obviously confers the ability to select the best lymphatic vessel on surgeons. Of course, in this case, we select the left one. Third, laser tomography can clearly visualize and identify the valves of the lymphatic vessels. In this study, valves, which were seen as white winding lines, this one, were found inside the lumen in 40% of lymphatic vessels. So, surgeons can know precisely where they should cut the lymphatic vessel for end-to-end anastomosis and avoid damaging valves when making a window in the lymphatic vessels for side-to-end anastomosis. Laser tomography can also clearly visualize and identify the double lumen. If we don't use laser tomography, we wouldn't even think this tiny lymphatic vessel has 2 lumen. So we can do very precise anastomosis using this stent. Number 4 is laser tomography can evaluate the anastomotic condition of LVA. Due to extremely high resolution of the images that can be obtained with laser tomography, the patency of the anastomosis sites can be more precisely determined, thus possibly leading to higher efficacy of LVA. Cross point of axial line and sagittal line was set on the anastomotic point, so we can evaluate very clearly. This is a longitudinal aspect. Here is the center of the anastomotic point. And also, as I told before, this machine can calculate the inside, the lumen of inside. The size of this lumen is 0.102. In this study, patency of the anastomosis sites could be determined in all anastomosis using laser tomography. 107 end-to-end anastomosis and 25 side-to-end anastomosis. So some anastomosis sites demonstrated inverted edges of the vessels, which necessitated immediate reanastomosis, even though the patency was confirmed with ICG observation. Again, the edge is inverted. Laser tomography may also be useful for beginner of lymphatic surgery because it provides immediate feedback of the anastomosis status. In this study, postoperative 1-year examination with ICG lymphography demonstrated patent in 110 out of 132 anastomosis, no patent in 4 anastomosis, and not seen in 18 anastomosis. Compared with 150 anastomosis without using laser tomography, postoperative 1-year patent rate was increased by 13% with significant differences. So recently, many supermicrosurgeons told that LVA doesn't work so much. That's why there is a trend toward lymph node transfer. I think this is wrong because most of them haven't detected appropriate lymphatic vessels before surgery. If we try to find functional and less sclerotic lymphatic vessel, which is responsible for lymphedema more precisely, we can maximize the efficacy of LVA even in moderate to severe fluid-predominant lymphedema. The concept of LVA is very simple, but I think many microsurgeons experience lack of result even if they found lymphatic vessel for anastomosis in the operative field. If the result of LVA is not good, it's probably the result of lack of attention to a specific detail, I think. So this is a key to maximizing the effect of LVA, and imaging technique is one way to approach specific detail. So this is my past protocol of imaging techniques. So getting the big picture using lymphoscintigraphy and ICG lymphography is of course very important. So this is my current protocol of imaging techniques. Finding the lymphatic vessel which has responsible for lymphedema and selecting the functional lymphatic vessel that can be expected to be effective for surgery. So new imaging techniques, ultrasound and laser tomography can visualize detail of the lymphatic vessel and bring us more information for maximizing efficacy of lymphatic supermicrosurgery. I never doubt that these new technologies take the surgeon to next level. So this is my conventional strategy for LVA, doing LVA as many as possible. But my new strategy for LVA is doing minimum necessary LVA with supervision. And last, I will explain about our new surgical techniques, lymphatic system transfer. I think this is a very strong transfer technique compared with lymph node transfer, conventional lymph node transfer. So, lymph node transfer, in the lymph node transfer, we harvested only small portion of lymph node, vascularized lymph node. But in our lymphatic system transfer, we harvest not only small portion of lymph node, but also many long afferent lymphatic vessels, which converged into this lymph node. So, and this lymphatic system flap will transfer to the lymphedema site. So these long, many afferent lymphatic vessels can drain so much excess lymph fluid in the lymphedema site. So this is a very strong point compared with the lymph node transfer, I think. Like this. So this is an example case. This is the most severe cases which I did operation in Kameda Medical Center. So she had a Halsted surgery in 25 years ago, and her lymphedema getting worse. And she couldn't come to my outpatient clinic without holding her arms, of course, because very heavy. She did compression therapy and exercise and skincare for last 20 years, but getting worse and worse. So I chose lymphatic system transfer for her. So now I harvested a skip flap, superficial circumflex iliac artery perforator flap, including the lymph node and 3 or 4 long afferent lymphatic vessels, which converged into that lymph node in inguinal region. And I put the lymphatic system flap from the axial side to the upper limb. Again, I put this flap from the axial side to upper arm. So, excess lymphatic fluid will be drained from these 3 or 4 long afferent lymphatic vessels and go up to lymph node and go up to via lymph node and go to these veins. So this is a postoperative course of 1.5 years after lymphatic system transfer. The result is amazing, like this. So now she can come to my outpatient clinic without holding arms, and she can grasp more than before. Of course, excess fat is still remain because I didn't liposuction. So I think this lymphatic system transfer is stronger, has a stronger power than lymph node transfer, I think. Okay, so the surgery for lymphedema with supervision were highly valued and our lymphedema center became the first Asian designated surgical centers of excellence because of these techniques, I think. So if you are interested in today's topic, always welcome to our center, and let's enjoy not only super microsurgery with supervision, but also beautiful nature and seafood. Thank you for attention and great hospitality in this time. 谢谢。